I'm Dr. Jame Abraham, Director of Breast Cancer Program and Professor of Medicine at Cleveland Clinic, United States. So breast cancer is a global problem. In the past 2 or 3 years, actually the incidence of breast cancer has overtaken cervical cancer. In the past, cervical cancer was the most common cancer in women, if you look at globally. In the past 2 years, breast cancer has overtaken that. So that's because of, and that's true in India also. And in the past, cervical cancer was the most common cancer in women. Now, breast cancer is the most common. That's due to many factors. I think one thing we can say is more and more of us are living longer. So it's a lifestyle disease. Our lifespan plays a major role. So when we live longer, the incidence of breast cancer goes up. Our lifestyle changes. Lifestyle plays a key role in breast cancer, especially our diet, our exercise, and some of the supplements we take, especially hormone replacement treatment. So when the socio-economic status of a society changes, our lifestyle changes. So that impact the incidence of breast cancer. So if you look at globally, that's what's happening. That's exactly happening in India also. And it could be, as I said, it could be two different things. Improvement in economic status changes the lifestyle. At the same time, it's bringing down the incidence of cancer of the cervix, which is a disease of poverty, because cancer of the cervix is due to an infection. And infections are more common in, if I can say, in less affluent communities. So the CA cervix is coming down, and the CA breast incidence is going up. Yeah. So breast cancer, we have really good understanding of what are the different types of breast cancer. There's one what we call as estrogen receptor positive, that's ER positive breast cancer, which has overall good prognosis. About 60 to 75% of breast cancers are ER positive. So when this in ER or estrogen receptor positive patients or breast cancer, the tumor is driven by estrogen or estrogen pathway. So we can use certain medicines or anti-estrogens to stop the production of estrogen, and that's an effective treatment for breast cancer. So the importance of estrogen receptor is two. One, it's a prognostic feature. Second, we have highly effective treatment. The second type of breast cancer is HER2 positive. So about 25% of the patients have HER2 overexpression. When the HER2 is positive, those tumors tend to be more aggressive. But in the past 10 or 15 years, we have highly effective treatment targeting this HER2 pathway. That's trastuzumab, pertuzumab, we have TDM1, so highly effective treatment. So after the development of this highly effective treatment, the prognosis of HER2 positive breast cancer is as good or even better than HER2 negative tumors. The third category is triple negative. So in triple negative, ER, PR, and HER2, those are the three factors. All three are negative. So we don't have a target. So ER positive, estrogen receptor is a target, HER2 positive, HER2 is a target. In triple negative, we don't have a target to treat. So triple negative breast cancers are the most aggressive forms of breast cancer. Usually it happens in younger patients. The tumors tend to be more what we say is proliferative. It has many of the growth factor overexpression, high grade, and then overall the prognosis is poor for triple negative breast cancer. So as I said, we don't have a target, and so we don't have an anti-estrogen receptor or anti-estrogen treatment or anti-HER2 treatment for these patients. Chemotherapy is the only treatment option for triple negative breast cancer. But in my talk today, I'm going to talk about some of the new treatments. There are many new antibody drug conjugates. Means it's an antibody which is bound to a a cytotoxic agent through a linker molecule. Many new antibody drug conjugates, Celldex-011 is one of this antibody drug conjugate which is being developed. That's one. Second, about 5 to 10% of breast cancer patients, the cancer happens because of a BRCA mutation. So in patients with BRCA mutated tumor, we can have, there are trials looking at the role of PARP inhibitors. So that's a new class of drug which can inhibit the DNA repair and which can cause the lethality of the cell. So PARP inhibitors are an extremely active group of drugs. The only PARP inhibitor which is approved by FDA at this point is olaparib, which is an AstraZeneca drug, which is approved by FDA for BRCA mutated ovarian cancer in third-line setting. So in triple-negative breast cancer, there are several studies going on. A large randomized study completed. It's known as Zinca trial, which is completed accrual in BRCA mutated patients versus standard treatment option. And there are 3 or 4 large randomized studies are looking at olaparib in adjuvant setting and again in metastatic setting. And there is an Abbott drug, ABT888, veliparib, which is actually looking at neoadjuvant setting. And then Tesaro has another drug, which is niraparib, which we are going to do a study in metastatic setting. So PARP inhibitors are a class of drug which is going to have, I think it's going to change the way we treat triple-negative breast cancer. So I talked about antibody drug conjugate. Second, I'm talking about PARP inhibitor. Third, immunotherapy. So I'm sure you're well aware immunotherapy is highly effective in lung cancer and some kind of renal cancers and colorectal and lymphoma. Now we have some trials looking at immunotherapy. Some of the really interesting data came from pembrolizumab, which is a Merck drug, which in 2014 at San Antonio, a group from University of Chicago presented the data about 18 to 20% response rate in heavily treated patients, again triple negative. So we have a prospective study going on right now in first line and second line and triple negative breast cancer, looking at pembrolizumab versus treatment of physician's choice. And then Roche has another compound, PD-L1 inhibitor, which is being looked at again in first line metastatic breast cancer. So that's the PD-L1, Roche PD-L1 plus nab-paclitaxel, which is a nanoparticle albumin-bound paclitaxel in first line metastatic. So there are several immunotherapy trials are going on. So again, antibody drug conjugate, PARP inhibitors, immunotherapy, and lastly, androgen receptor blockade. So that's a new class, again, a new class of drug. Enzalutamide, again, it's an AstraZeneca drug, I think. About 10 to 20% of triple negative breast cancer patients have androgen receptor. So if you use an androgen receptor blockade in triple negative breast cancer, some of the studies from Memorial Sloan Kettering showed up to 35% response rate in those subset of patients. So we have several exciting drugs coming in this area.
How do you see the future evolving?
I think it's like the HER2 positive, the trastuzumab and the drugs which are targeting HER2 really change the way the prognosis of HER2 positive breast cancer. I think discovery of some of these targeted agents in triple negative will change the natural history of this disease.